So I'm going to talk a little bit about TCAR, transcarotid revascularization, as compared to transfemoral carotid angioplasty and stenting. How do I choose? As Raj showed us, there's been a pretty substantial decline in perioperative or periprocedural adverse events as we've moved forward with these pivotal trials due to our gaining additional experience, better patient selection, and improvements in technology. So carotid stenting, transfemoral carotid stenting, I think is a better option than it has ever been in the past. So I think we have to take that into consideration when we're making our determinations. Another factor I think that's pretty well established is for transfemoral carotid stenting, at least with distal embolic protection, there seems to be a clear decrease in efficacy or increase in periprocedural complication rate as you get older. This was from the CREST trial, and it looked at patients once they hit the age of 70, they actually did better with endarterectomy than they did with angioplasty and stenting, and this was particularly so for those who were octogenarians or older. But this may not apply to proximal protection, and we touched on this a little bit, but you can see this is a patient with a pretty dramatic plaque, unstable with ulceration. And we go ahead and with the flow cessation, as we've alluded to, you have an occlusion balloon in the external carotid and an occlusion balloon in the common carotid. So you have flow cessation, and then you aspirate after each of the steps in the procedure to get flow reversal. And this has shown major adverse cardiovascular events of 2.7% and major stroke less than 1%. So that's represents a significant improvement over prior pivotal trials, and we did not see that increase in complication rates for the octogenarian population. Similar results were seen with the Gore flow reversal system, which is, again, not being marketed. How does this compare to TCAR? TCAR, we do direct access to the common carotid artery, so you avoid all the manipulation of coming from the radial artery and twirling a great big elongated reverse curve catheter in the heavily diseased aortic arch, which never results in any embolization, I'm sure. And you can just, through a small cut down, place your sheath here, and then there's a circuit that enables flow reversal through a filter into the venous system. And in doing so, you can do your angioplasty and stenting with flow reversal, and that way you're not subjected to potential small emboli passing through those microporous filters, as we've discussed. And that works well. I think the Roadster trial on an intention to treat basis shows, if you look at stroke death and MI, it's at 3.7%, which I think is right in line with some of our best therapies, particularly with proximal protection. And again, if you look at no major strokes and a low rate of minor strokes, and again, a mortality rate under 1%. So it seems to be very efficacious doing transcarotid stenting. So both of these therapies, I think, are valid for patients, and it's a matter of which patients do I apply which therapy or which approach. So this is a patient in whom we did transfemoral stenting, who had undergone endarterectomy, and then initial surveillance had been showed a widely patent endarterectomy site, and then at 9 months showed a 95% restenosis. Here's the CT scan. It's going to go pretty quick, but I'll show you the angios in just a second. But basically, you have a high-grade lesion at the carotid bifurcation in the area of the previous endarterectomy. And here's just a still image of that. Here's this 95% stenosis. I think it's visual, or maybe a little bit higher. Here's visualized on a sagittal MIP image. And the arch is pretty favorable. This would be a sort of type 1, maybe a type 1A sort of arch with the great vessels here. Here's your left carotid artery. But it's really off the top of the arch at a slightly reversed angle. So I think pretty favorable for transfemoral approach. It's a previously operated on neck. We've seen with restenotic lesions, angioplasty and stenting is pretty safe because typically those lesions are animal hyperplastic and more fibrotic in nature, so less prone to embolization. You can ignore, the patient also had disease in the right carotid, but here's the side with the high-grade restenosis. You can see here's the access vessel. Now it does have a pretty long run, so you really could do a TCAR as well in this patient. Let's just see if I can and get to the still image. So this gives you a pretty good, this is after we had the sheath in, so we put our wire, as is typical, into the external carotid, advanced our 6 French sheath into position. You can see very severe narrowing and sort of an odd configuration for restenosis, at least in terms of the experience I've had with these patients. And I think actually where there was really a dissection was present there on our imaging. And here I am getting the wire for the embolic protection device caught in the dissection plane, but ultimately we were able to advance that through the stenosis. And here, if you look, you see it's almost like a pseudospasm, right? So we have a pretty stiff wire in here with our embolic protection filter. So this is distal embolic protection. And there's very limited flow due to that. All that tortuosity has been straightened out by the support wire and results in sort of kinking off of the vessel. Here we're deploying our stent. This happens to be a closed cell stent. I think we've seen a fair amount of data on that. There's some other data that are relatively compelling in terms of reduced embolic potential, but again, nothing in a randomized perspective fashion. And here's our completion, so pretty good resolution, but again, you can see the vessels are kinked on itself here with the filter, and once we retrieve that, we get a nice result from that. So I think this is a patient in whom transfemoral stenting remains a very attractive option, probably the gold standard option. Patients such as this who had prior laryngectomy, has a permanent stoma, extensive neck dissection and radiation, so you're not going to do a TCAR in this patient. Trying to cut down, in this field is prone to infection from the stoma, the laryngeal stoma, and also extensive scarring. You can see how woody and scarred in all that tissue is. But the radiation seems to give them a potential for stenosis. It's typical in carotid, but in other areas as well. And so this is a patient in whom transfemoral stenting really is going to remain your best option. And here's the pre, and we were able to get good resolution of that stenosis. We talked about arch classification, just to go over it again. So these type 1 arches where the great vessels are really coming off the top or the greater curvature of the arch. Type 2 where they're sort of between the greater and lesser curvatures. And then type 3 where they're proximal to or inferior to the arch itself. And this is going to require a lot of additional manipulation to get access. So that I think is a legit, and also if there's disease, obstructive disease, heavy calcification in the arch at that level, I think those are all very strong arguments for transcarotid revascularization as compared to transfemoral. Here's a patient we actually did years ago with a transfemoral. So here's the arch. This is it also has a sort of replaced right subclavian. But if this, we went over types 1, 2, and 3. This is about a type 6 arch, I think, in terms of the approach, and we can do these cases. In this instance, we used a VTEC catheter, sent our wire up into the external, so you can then kind of advance the sheath over your catheter wire combination. But it's certainly not foolproof. You're doing a lot of manipulation through that arch, and I think we don't need to go to these sort of heroic lengths any longer to do carotid stenting in these patients when we can do a transcarotid approach for those patients. So I think those are instances in which really transcarotid is going to be favored. Here's a patient that we treated with a type 3 arch and a lot of tortuosity proximally. So not only are you coming up and seeing the difficulty with navigating the arch, but then you're coming back at almost 180-degree angles. So I think these are good examples of patients, at least patients that we've used transcarotid stenting. And here is we do the cut down. Here's our sheath. We like to make sure the sheath is, intraluminal, is not in a dissection plane. So you just want to look at it in 2 obliquities to ensure appropriate placement. And here we've done angioplasty and stenting. And we typically do not perform post-dilatation in these patients. Occasionally we'll do so. But again, that's the time in which the greatest embolic potential is present, even if you are on flow reversal. So we've tended to avoid that when possible. And this patient did well and was ultimately discharged. So one other case, this is sort of an interesting case. I'll just go through quickly. This patient had 2 prior carotid endarterectomies and now has a large pseudoaneurysm. We'll see it on the right as we come up here in this area. See a large aneurysm there, full of thrombus. So I think, there is a risk for rupture in these patients, but mostly the risk that we're concerned about is embolization. And you can see why with that extensive thrombus burden. And here's just a still image showing sort of the maximum projection of that pseudoaneurysm of the carotid. If we did an arteriogram, you can see this arch is quite unfavorable for transfemoral stenting, extensive calcification. If you look at the misregistration artifact here, you see there's a lot of calcium in the arch and in the ostia of the great vessels, and it's a type 3 arch with a bad angle to try to get back up into the brachiocephalic trunk and right common carotid artery. So not, in my estimation, not a good candidate for attempting transfemoral approach to this. And so what we did instead is a TCAR, sort of modified TCAR, right, because we're not really treating so much of stenosis as we are this pseudoaneurysm. But we got access here, and we placed overlapping closed cell stents within that distribution. And the patient's fully anticoagulated at this point, so there's a little slower flow into the aneurysm, but it's still present. That will subside as the flow is directed through the stents. And then on postoperative follow-up, there's no flow in the aneurysm. I'll just show the duplex scan. So this is the transverse image. Here's the stent. There's no flow in the aneurysm external to the stent. And that's very typical, and it's not this diversion of the flow. I think prevents subsequent embolization from the. And here's an sagittal appearance again. Good flow within the stent, no stenosis, and no flow outside of the stent, and that's pretty typical for these treatments. This is a patient that I did both treatments with. I did a TCAR first, and I don't know quite. I mean, part of the rationale for TCAR was in terms of trying to get a distal embolic protection device. It would be very hard to navigate through all this tortuosity. And so we went ahead and did our cut down and did transcarotid revascularization, more of a common carotid lesion. That may actually push you toward transfemoral, just because you typically will cannulate the external carotid to get your TCAR sheath into position, your en route sheath into position. So something to consider when looking at these lesions. Sometimes if it's a distal common carotid lesion, it may not be optimal for transcarotid revascularization. But it went well. Here's the lesion. Here's good resolution after we do our TCAR. We're about to take our wire out, come off flow reversal. But the patient, unfortunately, experienced a pretty rapid progression of restenosis with very high velocities and very high end diastolic velocities. So this was considered to be a 80 to 99% restenotic lesion. And so in this case, having been fooled once with the TCAR, and I went in and did a transfemoral stenting. Also used, the TCAR typically utilizes a open cell stent, and so there may have been some component of sort of recoil that was present, but here's the restenotic lesion in the midst of the previously placed stent. We go ahead and advance our closed cell stent and deploy that stent within the first stent and get a good resolution of that, and they've been free of restenosis since that time. So I'll just conclude by saying both transcarotid revascularization and transfemoral angioplasty and stenting are really complementary approaches. I think there are a lot of patients in whom either approach can be used safely and effectively. For patients who have difficult access, whether it be in the aortoiliac segment or most commonly in the aortic arch, those are really the ones in whom TCAR, I think, is really strongly favored as the initial approach. Transfemoral stenting appears to carry a lower physiologic risk. We see that in CREST and other trials where the myocardial infarction rate is really reduced for transfemoral, at least compared to endarterectomy, but you can sort of extrapolate that to transcarotid revascularization. You have to look and make sure the length of that common carotid is sufficient to allow enough room, enough runway to get the balloons and stents in place to actually introduce the system itself. So if it's a very short, or it's a low lesion, or it's a very short common carotid, transfemoral is going to be preferred to transcarotid. And there may be an advantage in terms of not having to do a dissection in an irradiated neck. Again, transfemoral may be advantageous in those circumstances. I do think calcium is a limitation for both approaches. Heavily calcified lesions just don't respond very well to the angioplasty, and you can see recoil and incomplete sort of opening up of the stent. Higher levels of embolization. People have talked about trying to use shockwave. I can't. That would certainly be off-label to utilize that approach. So heavily calcified lesions are sort of a limitation for both of these approaches. So thank you very much, and I guess we'll move on to our debate. You guys want to give your successor?